Oh, I have to
Yes.
speak in there.
Yes. A little speaker over here.
Oh gosh, that's annoying. Okay, here we go.
Would you ever have it not into the speaker?
It's just like because I have to stand so far away
Right.
from my slides. I mean, it's
Okay.
fine. I can do it. But it's a little bit here. Let me just put myself in here. I guess I can move it this way. Let's be a little closer. Let me take this off.
Hi there. We can move this closer, can we?
Sorry?
Probably
We
not.
can move this one closer.
Yeah.
Or maybe we can move the monitor a little bit closer.
Yeah, you can move the monitor closer.
Oh, like that.
There we
Oh,
away.
that's better. Yeah, it's just my eyesight.
Yeah, no worries.
So to be able to read it, it's
Yeah.
great. Okay, perfect.
And what about
Great.
that screen over there?
You're connected to the Zoom already.
Okay,
Yeah.
so it should be shortly.
Yeah, there's already 3 people
Yeah,
watching.
I'm one of them.
So-
You're one of them.
Yeah.
Excellent. Okay, and then, oh, so what this is just,
It is loading.
yeah, it's just loading.
Yeah.
Just a sec.
Hi, Dr. Castle.
And you can make it display it by clicking on this and hitting Lectern PC when you're ready. If someone else is presenting, you have to hit none.
Okay.
Yeah.
Let me just get it up here.
Yeah.
Actually, I need this. Let's see. Okay. And then slideshow.
Yeah. Yeah.
Got it.
So you will.
Oh, hey,
have
Barry, how you
to-
doing? Good to see you.
So then we hit Lectern PC, see what comes up. It's going to be this. So we have
want
to hit
that to come
display
up.
settings and we just swap it.
Okay.
There you go.
Excellent. Okay.
Maybe you and I.
We're going to be actually in the room.
You know, there were more and more people coming
Yeah, yeah.
before this last week with the masks and things. So I don't know.
Yeah, yeah, no, it's totally
I'm
fine.
glad you're here.
Yeah, I asked Val, I was like, because I'm like in clinic today and I'm like, can I do it from clinic? And Val's like, no, you should come in person.
Is she coming? Is Val coming?
She better be. No, I don't know. Maybe she'll be online. Who knows? Yeah.
It's so difficult to
Yeah.
ask people to
Yeah, I
present
know.
online. It's anyway, I'm glad you're here.
It's all good.
Yeah.
It's all good. When I go to the medical school, I go to in person as much as I possibly can to teach. And so it's fine. But yeah, like it's just it's also a beautiful day, you know, like it's just, you know, and these days are so few and far between right now that like, I wouldn't be surprised if some people are just like, I think we'll watch this from the park, you know?
I was going to ride in, but I'm going to ride after.
Yeah.
Because it really is.
Yeah.
It was a little chilly, not chilly, it's a little slick this morning.
Yeah.
You ride, right?
I don't. I walk. I'm a crazy walker.
Okay.
I walk to and from St. Paul's to home when I'm on service here,
Okay.
which is like an hour and a half.
Oh, good. Where do you
Yeah.
live?
Out by
Dunbar?
UBC, Dunbar. Yeah, exactly. So it's a good walk, you know, and up the hill and everything. But I don't know why. I like riding, but I don't like having to deal with the bicycle.
Well, yeah. But in any case, for the very reason that it's beautiful, but it's moist this morning and
Yeah.
with the leaves. So
Yeah.
I'm glad they did.
Yeah, no, I'm walking home today. Absolutely. Yeah. Yeah.
I will be into Zoom. I'll
Okay.
stay up in the office if you need anything.
Okay.
just let me know.
Thanks.
All right. I appreciate it.
Thank
Thank you. Thank you.
I'm
All right.
really excited about your talk.
Yeah. There's been a lot in the news, hey?
I haven't really
Followed it.
No.
Yeah. Maybe it's just an ID thing. We're always like sending each other these, or people send stuff to me because they know I'm an infectious diseases doctor. So if something comes up in CBC, I get a text about it. So yeah, that may be what it is. But
So are you, I haven't seen, are you doing service here?
Yeah, I do service. I do 8 weeks a year. So, but that's spread between urban health and ID consults and OPAT. So it's all of the above.
So you do a minimal amount of inpatient.
Yeah, exactly. Mostly I'm outpatient at BC Women's where I do my HIV clinic.
Right.
So, and I do a lot of teaching at the med school.
Is the woman from Israel still doing the HIV?
No, Naora's left.
Oh, where is she?
She actually went back to Israel.
Oh, is that right? Oh, boy.
Yeah. Her whole family is there. Her kids are there. And she's actually teaching for a term. She's kind of a guest teacher at a university in a medical school in Vietnam. So so she's there actually right now with all the craziness going on in Israel. She's actually in Vietnam, but it's hectic, right? Like what just happened. I mean, and I've been texting with her, and her whole family's been called up. It's just like insane. It's just
The whole thing.
a whole thing is terrible in so many ways.
I mean, the world is going.
The world is going to shit. And here I am talking about climate change and infectious diseases.
But I mean, so.
Yeah.
You and I aren't going to solve the problem.
No, we're not. But you're biking, so that's good.
Yeah, no, it's and today is a beautiful. Come on in.
Yeah. Hey, how are you? Good.
So I'll introduce you. Val is not here.
Yeah, for sure.
You have a very extensive file, but I might just.
Oh, just say
you have an interest in HIV and women's health.
Yeah, exactly. And I teach at the med school. That's the other big thing I do, I guess.
What's Shauna?
Oh, Shauna is it's a longitudinal cohort of women living with HIV in the Metro Vancouver area, many of whom are downtown east side sex workers, but it's basically a longitudinal cohort of women living with HIV. And they've been running for years and years and years.
Oh, is that right?
Yeah. Yeah. Hey, how you doing? I love it. I'm going to see all these people that I, never see except when I'm on the wards here. Oh yeah, I don't know. It doesn't.
How's she enjoying being here?
I think she's enjoying it. It's a lot though. I mean, especially the transition to the new St. Paul's.
Yeah.
You're not retiring before that, are you?
I am.
You are retiring? When before the new St. Paul's?
I stopped my outpatient clinic a year ago.
Oh my
I'm
gosh.
just doing inpatients. I did a project for the hospital until the end of August, which is the associate physicians, the foreign medical graduates get a degree into systems. So I did that. And I've been doing consult medicine. I was doing 1 to 2 weeks a month.
Okay.
Now I'm doing 1 week a month. It's time.
1 week a month is a lot though still.
Yeah,
like that's
it's every 7 days.
Yeah.
7 full days.
Yeah.
27 times 24.
But you're not going to go to the new St. Paul's?
No. Well, I maybe go there, but
yeah.
I'll be
but you'll be a patient. You'll be an inpatient there. Okay.
Different situation. No, I think the hardest thing though is that I enjoy this.
It's hard to give it up. Yeah.
It's not so. It just is. When you don't like doing something, you find alternatives. But I've always enjoyed medicine.
Of course.
So
it's
not like this is a new thought.
I know. No, I know. I feel like, you kind of just pare back the things that are until you get to that one core thing that you just can't give up because you love it so much. It's just yeah, exactly. Exactly. Yeah.
So in any case,
this is going to be my HIV practice because it's my longitudinal HIV practice. I've known these people forever, but I joke with them all the time because I'm like the same age as the patients. They're all like in their late 40s, early 50s. And I joke with them all the time. I'm like, when you are with your walker, I will be here with my walker. We'll all be taking care of you.
It's more true than you know.
Yeah, I know. Oh, I better turn my cell phone off here.
Yeah, that's also where we know in terms of time.
Oh, Val said, wait, I have a text from Val. Hopefully she's not, maybe she's saying something. On my way to see you. Sorry, I'm late. That's okay. So we'll get it started here. I'm gonna
Is
turn
it-
this off.
Is it a full hour?
Yep.
Should we wait like a couple minutes?
I think we should probably get started.
Okay,
Just
all right.
because
Sure.
I don't know, like, I think I'm worried I want to have time for questions and
Yeah, yeah,
stuff.
yeah.
And I actually don't know exactly how long it is.
Good.
So.
Welcome to Grand Rounds and welcome to Grand Rounds in person. For those of you that are on Zoom, welcome to Grand Rounds. And just give a forward land acknowledgement. And I acknowledge that we're gathered and are grateful to live and work and play in the traditional and ancestral and unceded territory of the Coast Salish people, the Squamish, Tsleil-Waututh, and the Musqueam nations. Today's Grand Round is going to be given to us by Dr. Mary Kestler, who's an infectious disease specialist, part of the UBC division. She's got many activities. She's worked in Africa. Her interests are HIV and TB. She runs a longitudinal HIV clinic. She works at the Women's Hospital. She's creating curriculum for the medical school, and has a broad interest in social justice as well as infectious disease. The title, as you can see, are the effects of climate change on infectious diseases in Canada. Mary.
Okay. I hope it's okay. I'm going to take my mask off. It's going to be a lot easier to do this without that. Thanks, you guys, for coming in person. We happy few. But it's also welcome to everybody who is online. I will do this and then stop for questions at the end, and hopefully we'll have some time for discussion. This is effects of climate change on infectious disease in Canada. And over the next hour, I hope that you will be able to understand how climate change increases infectious disease prevalence, know which vector-borne diseases we may see more of in Canada, understand how rising coastal water and soil temperatures may impact disease incidence, and be able to, at the end of the talk, diagnose and treat some emerging infections due to climate change in BC. And I just want to say from the outset that there are so many different infections worldwide that will be increasing in incidence due to climate change, things like malaria and dengue and other vector-borne diseases. I am not going to focus on everything. What I've decided to do is focus just on a few diseases that will have the most local increases here in Canada and in British Columbia, things that have local relevance for us. Okay, so let's talk first about the current state. Where are we when it comes to climate change right now? This is data over the last century of both temperature and precipitation. So if we look at BC, overall, we have warmed across the province 1.4 degrees centigrade or Celsius since 1900. But that is not spread evenly over the province. In the northern areas of BC, we have an increase of 2 degrees Celsius. In the coastal areas of Vancouver Island, Vancouver, we're 0.8 degrees Celsius, which is more in line with global averages. In terms of precipitation, we have seen an average annual precipitation increase of 12% in the past century. But again, we see regional variations. So in the interior, in the Kootenays, 21% increase in precipitation, and in the coastal areas, more around 14%. If we look at Eastern Canada between 2000 and 2015, this is the change in annual cumulative degree days above freezing in forested areas. And why is this important? It's important because it helps determine the northern range of Ixodes ticks, or ticks that bear Lyme disease. So what we can see here is the darker red areas are the places where you have the greatest number of increase of annual days greater than 0 degrees. And in some areas of Ontario and Quebec, you have greater than 35 days now over that 15-year period of time, 35 more days over 0 degrees in forested areas. So quite a difference, and you can kind of get that in one snapshot. So this is, again, current state where we are now. But looking into the future, again, we are projected to become hotter and wetter over time. In Canada, we are projected by the 2070s to have an increase of 5 degrees Celsius. In some areas of northern Canada, we're talking about 8 degrees Celsius difference in temperature by the 2070s. That's really remarkable that is what is projected right now. So, and in terms of precipitation, we may have smaller increases in precipitation across the plains, but in the north of Canada and in the interior British Columbia, we are projected to have significant increases in precipitation. And of course, as many of you know, a lot of this precipitation is going to come not gradually over the year, but in big extreme weather events where we are likely to have flooding. When we look at human infectious diseases, it's very difficult to tease out climate change as an independent variable. There are so many things that impact incidence of infectious diseases, things like the health system, globalization, urbanization, food systems, clean water, poverty, migration patterns. All of these things matter, and only one of which is climate change. So it can be difficult to say, okay, it's just climate change causing this increase in disease, because there is a complex web. But that said, climate change is likely to impact infectious diseases in 3 ways. The first is that temperature and rainfall pattern that we've just been talking about, directly enhancing the growth and the development and survival of human pathogens and their vectors. And that's vector-borne pathogens. That is water and food-borne bacterial pathogens and endemic mycoses. And endemic mycoses are basically fungal infections that have very specific environmental niches. We call them dimorphic fungi because they exist as molds in the environment, yeast when they get into the human body at human body temperature. And endemic mycoses like coccidiomycosis or cryptococcus or blastomycosis are also projected to increase with climate change, with increases of temperature and rainfall patterns. We also are going to have forced population migration and human densification. This is going to introduce new pathogens to our environment here. And also, as we well know from the 19th century, crowding and poor sanitation, malnutrition increases human susceptibility and communicability of disease. And then finally, extreme weather events. We can think about all of the fires that we had across Canada and North America this summer, decreases in air quality, increases in lung inflammation, which predisposes people to respiratory infections, and then finally flooding that overwhelms sanitation and vector control systems. But I'm really going to focus up here on vector-borne pathogens, water and food-borne bacterial pathogens, and endemic mycoses today, and hopefully give you guys an example of each of these.
Yeah, just all the way over there.
Can you ask them?
Yeah, can you guys just make sure that you mute? Thanks. So what changes in vector-borne disease can we expect? If we look at Canada with our warming climate, we are going to see a number of things. We're going to see increases of epidemics or reemergence of infectious diseases that we already have here. So increasing frequency and increasing severity of diseases that already exist. We are going to see the northward migration of vectors from North America, ticks, mosquitoes, and we're also going to see, we also will experience some infections that may not be endemic to Canada, but novel pathogens that will be brought from other areas of the world where climate changes are happening. And that's, of course, introduction of exotic vectors and other pathogens. It's also worthwhile to remember that the Canadian population is aging. We are becoming more medically complex all the time. The degree of immunosuppression of our patient populations is increasing, and that this is exactly the groups of people who are going to be most vulnerable to infections with climate change. So I'm going to switch gears now. We're going to talk about Lyme disease. It's impossible to talk about climate change in Canada without talking about Lyme disease. And I'm just going to remind you guys about the main players. So the bacteria, it's a spirochete. It's Borrelia burgdorferi. And this bacteria infects small ground-dwelling birds and mammals. In British Columbia, the deer mouse is the most important reservoir animal for Lyme disease. Then we have the vector, which is the Ixodes tick. Ixodes pacificus here and Ixodes scapularis in the eastern part of the country. The tick feeds on the reservoir, picks up the bacteria, and then when it feeds on hosts, which are white-tailed deer, humans, or dogs, it transmits the bacteria to us, and we can or cannot develop Lyme disease. Ixodes tick species and Borrelia, the bacteria species, vary across the world. In North America, Borrelia burgdorferi is our most important Borrelia species, but in Europe, they have other species of Borrelia. The tick species, again, here on the western edge of North America is Ixodes pacificus. This is our local black-legged tick, and Ixodes scapularis in the central and eastern parts of North America. And then Ixodes rincinus is the most common tick vector in Europe. There are other less pathogenic species of Borrelia that can cause disease in humans of variable intensity. Borrelia mayoni and Borrelia miyamotoi have both been identified in ticks in British Columbia, but are not known to have caused human disease at this time. If we look at BC and Lyme disease risk areas, this is ecological niche modeling that was done a number of years ago, looking at the optimal conditions for the tick vector for Lyme disease. Now, ticks need, again, that cumulative days of over 0 degrees. That's one of the temperature is the single most important factor, but they also need leaf litter, and they need low-lying vegetation, and they need water source, and they need hosts, and they need a reservoir. All of those things go into the model to try to predict where we're going to see, where we see Lyme disease now, where are the risk areas for the future. And really, if you look at BC, the modeling suggests that we probably will not see a major range expansion of Ixodes and Lyme disease in British Columbia, but that we may see more intensity of Lyme disease in the areas where it already exists. If we look at Canada as a whole, so this was a study that looked at the upper temperature limits for Ixodes scapularis. It published back in 2006, and they were making projections based on current climate models of where the Ixodes tick range would be at different time points. So if you look at the 2020s, which is the dark blue line here, this is where it was projected in 2006 to be. And in fact, if you look at tick surveillance from PHAC, in 2020, all these little brown dots, that's where Ixodes scapularis ticks were submitted through passive surveillance. Out here is Ixodes scapularis. But what you can see is that they were spot on in terms of where they were predicting Ixodes scapularis, the upper limit of the range. And 2050s, it's going to be higher, 2080s even higher. So we are going to see a significant increase in range of the tick vector in Canada. What about the number and incidence of Lyme disease in Canada over the last decade? It's certainly been increasing. So back in 2010, we had 143 cases reported. We just started reporting Lyme disease at a national level in 2009. But in 2010, we had 143 cases and a steady increase over that decade. In 2022, the most recent publicly available data was 2,168 cases, but 2021 saw over 3,000 cases. So absolutely, Lyme disease cases, even with increase in knowledge and reporting, is increasing in Canada. Geographic distribution of cases, Ontario certainly sees the lion's share of Lyme disease, absolute number of cases, followed by Quebec. But then if you look at Nova Scotia actually has the highest rate of Lyme disease in Canada with about 34 per 100,000 population. It's just because the per capita, the Lyme disease is much more common there. What about British Columbia? So this is Lyme disease we've actually been, Lyme disease has actually been a reportable disease in BC since 2003. And again, 2009 in Canada as a whole. So the blue line is the regional rate of Lyme disease. Orange line is the Canadian rate. In 2019, which is the last time it's reported at the BC CDC, we had 16 cases of reported Lyme, 8 of which were acquired in Europe, 4 of which were acquired from outside BC, and only 4 of which were thought to be local transmission of Lyme disease. That's 75% of the small amount of Lyme that we have here was locally transmitted. We do tick surveillance. It's been ongoing since 1993. Last survey was 2015. They go out and they drag in the woods to collect ticks with active surveillance. 893 Ixodes ticks, 5 were DNA positive for Borrelia. That's less than 1%. 483 rodents were collected. 41 were antibody positive for Borrelia. This is consistent with data and tick surveillance in the Pacific Northwest of the United States, and there hasn't been significant change over time. So I think what we can conclude from this, and we actually do really good surveillance here in BC, that Lyme disease is probably underreported here, as all diseases are underreported. It's underreported, but it's still not at the level that we see in areas of Eastern Canada. How do we do tick surveillance? So tick surveillance is both passive and active. Passive is basically people find ticks on themselves or on their pets and they give them to a health provider or the public health service. That's passive surveillance. Active surveillance is where public health goes out and in wooded forested areas, they are dragging fabric to try to collect ticks and do a sample of those ticks to find out how many are infected. And if we look at passive surveillance, now passive surveillance in Canada, I know this is a busy slide, but I'm going to take you through it. So this is looking at data from 2020. If we look at passive surveillance, they collected 718 Ixodes pacificus ticks. These are all from British Columbia. Not a single one was infected with Borrelia burgdorferi. One was infected with Borrelia miyamotoi. If you look at Ixodes scapularis ticks, again, submitted to public health by healthcare people and healthcare providers and veterinarians, over 7,500, about 17% were infected with Borrelia. But then we also do active surveillance in a number of provinces. And if you look at active surveillance in Ontario, 41% of ticks out there in the woods, in the surveillance areas, are infected with Borrelia. In Quebec, it's 36%, New Brunswick, 24%. So these numbers are in line with what we see in areas of New England and Minnesota and Wisconsin and very heavily Lyme endemic areas of the United States. How do we submit a tick in British Columbia? How might you do that or instruct your patient to do that? So e-tick is a really interesting web-based community surveillance mechanism that the government of Canada is really encouraging people to use. It's fantastic. You can download this app for your phone and you basically take a picture. You have a tick, you take a picture of the tick, you submit it. Experts then look at the tick and make an identification. They give you explanations about how to take a better picture of the tick, how to remove the tick. It's really a wonderful site. And then you end up being able to see all of the different ticks that are collected from your local area. So I go in there and I'm looking at British Columbia, and we have this most recent tick was submitted on July 26th. That's the picture of the tick. They were able to tell from that photograph that it was Ixodes pacificus in Nanaimo, found on a human. And this is how so much passive surveillance is now being collected. And even some of this went into that 2020 data that I just showed you. So please consider having people use e-tick to submit. But you can also submit a tick to BC CDC using the parasitology form. You should tell your patients to keep the tick in a sealed container with a wet cotton ball to keep it alive. If you can't keep it alive, it's okay. Dead ticks should still be submitted. Just make sure you put the source of the tick, the location it was found, the person bitten, etc. Testing is free for humans. And we should submit it as soon as possible to the BC Public Health Lab Parasitology Division. Vets also can submit ticks on their pets. So if you guys find a tick on your dog, your vet can submit that also. It does cost money, unfortunately, but it's the same requisition process for humans. All right, let's talk just a bit about Lyme disease now. So this is a reminder. I know we don't see a lot of Lyme disease in British Columbia, so this is a good reminder. Lyme disease, it follows sort of a similar pattern to the way syphilis evolves. We have an acute phase, which is in the first month, which is characterized by erythema migrans, that rash, fever, chills, headache, migratory arthralgias, and lymphadenopathy. After that phase, we call it a convalescent phase or early disseminated disease. And this is where you can have multiple erythema migrans rashes. You see neurological disease, which could be aseptic meningitis or encephalopathy. Bell's palsy is quite common, polyneuropathies. And then cardiac disease, which is much more rare, but cardiac Lyme can cause AV block or acute myopericarditis. If someone is not treated, they can go on to develop late disseminated disease. And that is your classic Lyme arthritis, could be a monoarticular arthritis, chronic arthralgias, or late neurological disease. Erythema migrans. I hope everybody has this image burned into their mind, because this classic bullseye rash of erythema migrans is pathognomonic for Lyme disease. It looks like this with the central clearing. It also has its size matters. So usually it's a 5 centimeters or above. Anything less than 5 centimeters, erythema that doesn't have the clearing, is small and is just surrounding the tick before it comes out, that is a hypersensitivity reaction to saliva. That is not erythema migrans. Okay, so this is what erythema migrans looks like, but unfortunately, only 40% of EM is classic. You can have a large circular expanding rash without central clearing. You can have a central eschar. You can have multiple lesions. You can even have vesicular crusting looking disease surrounded by erythema. All of this can be erythema migrans. So know the classic, but also know that it can vary. How do we test for Lyme disease? We are doing 2-tier testing. This is an ELISA antibody test. First, if that result is positive or equivocal, we go on to do a confirmatory test with immunoblot. If it's within the first 30 days, we test IgM and IgG. If it's after that in the convalescent phase, we only test IgG, because IgM can be a false positive at that point. It's unreliable. If the person has a travel history to Europe or Asia, then we do specific European immunoblots to see whether we can pick up Borrelia species from Europe. If it's negative, that first screening test is negative, and the patient still has signs or symptoms that you're still thinking Lyme disease, it's important to redo the test 3, 6, maybe a month, 6 weeks later, maybe a month or 2 later. And the reason for that is because the testing sensitivity really matters what stage of disease it is. If you are in that first month erythema migrans stage, your test sensitivity is only as high as about 50%. If you're in the convalescent stage, early neurological disease can be up to 76%. It's not until we get into the late disease stages where you see really, really reliable sensitivity. So this is why it's important to redo the test if you're suspicious. And again, this is the public health form. You can download it from their website, Zoonotic Diseases and Emerging Pathogens Requisition. You can check antibody. There is also PCR testing for Lyme disease. It's not recommended for the most part, but if you really needed, you had some synovial fluid or CSF that you wanted to test, you can do so with a PCR, but you definitely should call microbiology to get approval or discuss the situation first. So some important points about treatment of Lyme disease. Empiric treatment is for classic erythema migrans only. You don't have to test in those people. Remember, testing is insensitive at that stage. So don't test, just treat the patient. Prophylaxis after a tick bite. This is really going to be for those of you who ever wind up practicing in more endemic areas of Canada than British Columbia. But prophylaxis after a tick bite is only for people who you can confirm it's an Ixodes tick, it's a highly endemic area, and the tick is attached for at least 36 hours. That's how long it takes to transmit Borrelia to the host. And that's just a single dose of doxycycline for prophylaxis. The majority of people that we encounter with Lyme disease, we are going to be treating with doxycycline. It's really a mainstay of treatment. We can also use amoxicillin and cefuroxime. We really try to do oral treatment with doxycycline, but then, if you have central nervous system disease or Lyme arthritis, especially refractory Lyme arthritis, that's when we would want to use IV ceftriaxone. Now, what about the persistent symptoms of Lyme disease after treatment? Some people call this chronic Lyme. About 10 to 20% of patients are going to report persistent symptoms, and it's classically fatigue, joint pain, neurocognitive deficits. Some people will describe it as brain fog, up a year or so after treatment. And these are persistent symptoms and can be very debilitating for people. Prospective controlled trials, however, have followed healthy controls for months to years alongside these Lyme patients. And both groups, it turns out, have the same frequency of this symptom complex. So it turns out that this symptom complex is fairly common in the general population in the first place. So I don't know what it is. We don't know exactly what it is. It's likely some chronic inflammatory condition that we don't really have a good way to diagnose or treat at this point. But what we do know is that randomized controlled trials looking at antibiotic treatment don't work. It doesn't work. So 3 months of IV and oral antibiotics do not improve quality of life. They don't improve cognitive function or physical or mental health in people. 3 months has been compared to 2 weeks of antibiotic therapy in these groups. There's no significant difference between those. A third of patients in these trials improve, a third stay the same, and a third get worse. And that is not inconsistent with untreated rheumatoid arthritis over time. And there is, of course, a higher rate of adverse events in patients who are receiving antibiotics compared to placebo. So the bottom line is, we don't know what the persistent Lyme symptoms are. It's likely a chronic inflammatory condition. Antibiotics do not work to treat this. And I don't know if any of you had seen this from the CDC. This is just a couple of days ago. Canadians traveling to Mexico for Lyme disease treatments, people spending upwards of $50,000 on prolonged antibiotic therapy, hyperthermia treatments, other treatments that are not scientifically proven for Lyme disease. This is big business. And people are doing this. And I think it really illustrates the desperation that people get into when they have symptoms. The symptoms are real, but we don't have adequate treatment in our medical system right now. Let's switch our attention now to West Nile virus. This is another vector-borne disease, Culex mosquito. West Nile virus is primarily a bird virus. What happens is early in the spring, Culex mosquitoes, when they hatch, begin feeding on birds. And over the first half of the season, the virus is amplified in the bird population between mosquitoes and birds. And it's not until later in the summer when Culex mosquitoes that bite both birds and mammals emerge and begin spreading the West Nile virus to mammalian hosts, most importantly, horses and humans. Now, you can spread West Nile virus between human to human transmission as possible in the blood supply. We screen blood to make sure that it is not West Nile virus infected. It can be transmitted in organ transplants. It can be transplanted across the placenta in breast milk. But in general, humans get West Nile virus from being bitten by a Culex mosquito that is infected. There are 4 types of surveillance that we do in Canada. We look at mosquito pools. We try to determine what proportion of them are infected. We collect dead birds. Anybody who finds a dead bird, especially if it is a raven, a magpie, a jay, a crow, it's really that family, the corvid family of birds, that is most likely to be infected with West Nile virus. Those dead birds should be submitted to the Canadian Wildlife Health Cooperative for testing. And then cases of sick horses or sick humans that are tested positive for West Nile virus are reportable at provincial and national level. If we look at the data from US CDC, this is from 1999 to 2022. This is all the cases of West Nile virus that have occurred in the United States. What we can see is that the overwhelming majority of cases happen in the late summer and early fall. Okay, so really beginning in June, ending in November. But as we have an earlier onset of spring every year, we can imagine that the amplification cycle is going to be longer, and that may increase the volume of virus in the population, which may then lead to increase in human infection. This is reported cases of West Nile virus infections in humans, horses, and positive mosquito pools from 2015 to 2020 in Canada. And I think what we can see here is that mosquito pool positivity tracks very nicely along with human cases of disease, horses, and birds. Okay, the PHAC website has a really fantastic interactive tool that you can look weekly during the season to see what West Nile virus surveillance is in Canada at that time. So as of October 10th, just 2 days ago, I had a look at it. You can scroll over the province and it will tell you exactly what your West Nile virus situation is in the province. I chose Ontario because that's where the highest burden is in Canada. As of October 10th, there were 40 human cases, 298 positive mosquito pools, 5 positive horses, and 50 positive wild birds, dead wild birds. In BC, we've had 1 case of West Nile virus this year. We usually have somewhere between 0 and 2. This year, we had 1 case so far. It's been reported to the BC CDC. It was likely travel associated, not locally acquired. In fact, there's really only, I think, 2 cases of locally acquired West Nile virus that have been reported in BC since we've been checking. There were no bird or horse cases this year. Across Canada, and this is also weekly updated during the season, there have been 53 so far this year clinical cases, half of which have been neurological, 6 asymptomatic cases, and 1 death. If we look to our neighbors in the south, they are also doing all of this surveillance, and we can see that their data is not that different than what ours is in BC. Now, we don't do mosquito pool testing in BC, but they do in Washington State. All of these gray counties are where mosquito pools are being tested. They've had 3 human cases this year, all of which were locally acquired. They have 28 positive mosquito pools, 2 horses had at West Nile, and no birds. But just helpful sometimes to look south of the border to understand what we can expect here. Looking forward, these are projections. The most important factors for West Nile virus are the maximum temperature of the hottest month of the year, along with rainfall patterns. And so putting these into the model, this is a model done by UCLA, looked at where we can expect to see probabilities of West Nile virus into the rest of the 21st century. And what we can see just at a glance is the bright red and dark red areas are extending significantly into Canada. So I think West Nile virus, while it is not common here now, is something that we may very well see in the future. If you want to make the diagnosis, symptoms and diagnosis of West Nile, when should we expect it in people? Most patients are asymptomatic. You won't even know that it's there. So probably there is some West Nile virus going on in BC right now, and we don't even know about it. Symptoms, for symptomatic patients, it's a nonspecific viral illness. It is fever, headache, myalgias, arthralgias, rash. 1 in 150 people will develop central nervous system disease. Most of this is going to look just like aseptic meningitis, encephalitis. Some people can have acute flaccid paralysis. The highest risk, of course, is in older folks and people with immune suppression. And mortality is not insignificant. For people who have severe central nervous system disease, mortality is 10%. I really encourage everybody to suspect West Nile virus in anyone who has an acute febrile, especially neurological illness in summer or early fall. So the time of year really matters, especially if there have been mosquito exposures. Diagnosis is with an IgM on either serum or CSF. We can also do PCR, and treatment is just supportive. And of course, this is the virology requisition form that asks you to fill in this for West Nile virus. All right, so what changes in waterborne disease can we expect? One of the most interesting bacteria, gram-negative rod Vibrio, comes in 3 species, 3 important species for human disease: Vibrio vulnificus, Vibrio parahemolyticus, and Vibrio cholerae, which is cholera. Essentially, we've all heard of cholera outbreaks around the world. All Vibrio lives in ocean or brackish water, and it is highly correlated with sea surface temperature. Temperatures over 15 degrees Celsius, Vibrio thrives. The higher the temperature, the greater the Vibrio concentrations. Risk factors for Vibrio infection are eating shellfish, especially oysters, raw shellfish, especially oysters, and wound exposure to seawater. This is not you're just swimming in seawater and you have intact skin and it's okay. This really, the risk is people who have skin breakdown and a wound, something, and it's exposed to seawater. Human disease is either gastroenteritis, which can be self-limited, or it can be severe in the case of cholera. Cellulitis, which can be mild, or it can be very severe and rapidly progressive to necrotizing fasciitis. So it's important to recognize it early. If we look at Vibrio vulnificus wound infections in North America, this was in Nature earlier this summer. They basically tracked wound infection data going back to 1980. Back in 1980, Vibrio vulnificus was rare north of Georgia in the United States. But by 2018, Vibrio was regularly reported as far north as Philadelphia. And in that period of time, wound infection rates increased eightfold. Assuming that we have the same medium to high future emissions and warming, by 2041 to 2060, Vibrio will be common around New York City and the high population centers of New York City. And then finally, by 2081 to 2100, Vibrio will be at risk at every Eastern US state. And I think we also have to consider, of course, New Brunswick and Nova Scotia, as that is contiguous coastal. If we look at British Columbia, we have Vibrio parahemolyticus primarily here. This is a study looking from 1992 to 2017, correlating Vibrio cases with the maximum sea surface temperature. They correlate very nicely. We actually did have a very big outbreak of Vibrio here in 2015. About 7,500 Canadians were estimated to be impacted by that outbreak. There were 82 cases reported, but about 7,500 people estimated to be impacted. Now, since that time, there have been some changes made to shellfish harvesting sites and shellfish handling to try to reduce Vibrio cases. We actually, the BC CDC has this really awesome interactive sea surface temperature map that looks at all of the shellfish handling sites in British Columbia. And you just have to scroll over each site and it will give you the sea surface temperature for the last 2 weeks during the Vibrio season. And so I looked in September 17th. And by the way, this is not really sea surface temperature. This is satellite data, and it actually is a measure of the temperature of the ocean about 10 meters below the surface. So it's colder than sea surface temperature. But nevertheless, this was September 17th to September 30th. We can see that it's not even until September 24th that the sea surface temperature is consistently below 15. And remember, 15 is that threshold where Vibrio begins to thrive. I actually looked at this data back in August, and there were only 2 sites at that time in British Columbia, Brentwood Bay and Souk on Vancouver Island, that were consistently below 15. Every other site was well above 15, sometimes 20, 22 degrees. So this is late season that I'm showing you here, but it's really interesting. You can look and see what these risks are. Okay, as of September 9th, there have been 12 cases of Vibrio parahemolyticus in BC, and that is very consistent with our average over 2018 to 2022, the last 5 years. And again, there have been a lot of things put in place after that outbreak that we had to try to reduce risks, mostly keeping shellfish cold. Cholera on Vancouver Island. Yes, it has happened. Crazy. 4 cases in March of 2018 of Vibrio cholerae on Vancouver Island. It was linked to the consumption of contaminated herring eggs harvested off the coast. How in the world did this happen? Mostly we think of cholera as a travel-associated disease in Canada. Johns Hopkins University actually did a big study of how this could have occurred. And what they found is it was really a perfect storm of untreated wastewater that was dumped into the Strait of Georgia from Vancouver, coupled with heavy rains that overwhelmed sewage and rainwater systems, along with rising ocean temperatures and earlier zooplankton blooms. Zooplankton also is infected by Vibrio. And so earlier blooms meant an increase in Vibrio populations. All of these things, it's worth noting, although I don't think we're going to have, I think we're going to have a lot more Vibrio parahemolyticus than we are Vibrio cholera, but it's worth seeing that these are the kinds of things that are happening with increasing sea surface temperatures and increasing extreme rainfall events. In terms of symptoms for Vibrio, remember it's gastroenteritis, acute onset of diarrhea, usually watery, not bloody, crampy abdominal pain, nausea, vomiting, fever are classic gastro. Symptoms usually emerge 12 to 24 hours after ingestion. They're self-limiting in 3 to 7 days. Please suspect Vibrio in any patient with acute gastroenteritis after eating shellfish. in late spring and early fall. In terms of cellulitis, and I would say I see a Vibrio cellulitis about once a year at St. Paul's, and I'm not on service that often, and I see it probably once a year. It's a wound infection after seawater exposure, shellfish, or fish handling. It's usually mild, but it can rapidly progress to myositis and neck fash and even septic shock. The highest risk of that severe progression is going to be in immunosuppressed people, particularly people who have diabetes or cirrhosis. Again, suspect Vibrio in patients with cellulitis or wound infection after seawater exposure that is rapidly progressive or does not respond to your typical beta-lactam therapy. Diagnosis, it's on the new panel, the new multiplex GI panel. So that's very helpful for us from stool, but we can also culture deep tissue wounds, stool, vomit, urine, or blood. And then treatment, mild self-limited cases don't need to treat, but your immunosuppressed patient, your older patients, severe diarrhea, definitely treat. Anybody with significant cellulitis or wound infection needs treatment, and it's double therapy with doxycycline plus ceftriaxone. Alternatives are Azithro or Cipro. And remember, as in any neck fash, early surgical debridement is life-saving. What changes in soil-borne disease can we expect? I don't know if anybody saw this over the summer, danger in the dirt on CBC, a look at coccidiomycosis, or what we call valley fever. Now, cocci has usually been a disease that we don't have here in Canada. It's really a disease of the Central Valley of California and Arizona. But there have been cases as far north as Washington State. Cocci comes in two species, Cocci immitis and Cocci possidacei. Cocci possidacei is more common in Arizona and immitis in California. The way that this is one of those endemic mycoses that I was telling you guys about that exists as a mold in the soil. And mycelial growth is really facilitated by a rainy season. So you've got to have a rainy season to get that mold growing and thriving and spreading, and followed by a dry season. Soil dries up, spores form and become aerosolized, and wind blows, dry, desiccated drought season, wind blows, and people breathe in the spores, which then can cause disease. Wet winters followed by hot, dry summers increase transmission. The highest incidence is, like I said, in periods of drought. The limiting factor for coccidioides in the wet areas, cooler, wetter regions, is your summer temperature. And in the limiting factor for coccidioides in arid regions is winter precipitation. And this is important because in British Columbia, this is exactly the situation we are going to have. Warmer, hotter summers in our cool, wet areas, and more precipitation in our hottest areas in the interior. California has seen in a major increase in coccidiomycosis between 2000 and 2018. It increased 8 times. Between 2014 and 2018, rates tripled. And we can see again the maps, projected maps. This is coccidiomycosis cases in 2007, by 2035, by 2095, right up here against the BC border. Many patients, most patients are asymptomatic. It's similar to other endemic mycosis or even tuberculosis. Once you breathe in spores, that your body's immune system can contain it. It can reactivate years later with immune suppression. Symptomatic patients have acute pneumonia. That's what we call valley fever, characterized by fever, cough, chest pain, myalgias, fatigue. Interestingly, erythema nodosum, along with a community-acquired pneumonia, is a classic sign of coccidiomycosis or valley fever in endemic areas. Usually for the pneumonia, it tends to be a localized infiltrate, nodular cavity on chest x-ray, and symptoms generally form about 1 to 3 weeks post-exposure. I think it's still important for all of us to understand coccidiomycosis because we have plenty of Canadian patients who are going down to Arizona and Central Valley of California to Palm Springs every year to spend the wintertime. Small minority of patients will have disseminated disease, skin, bone, joint involvement, and meningitis. And risk factors for disseminated disease are impaired cell-mediated immunity, diabetes, African or Filipino descent, and pregnant women. So pregnancy in second and third trimester, as well as postpartum and older adults. EIA ELISA is our standard test. It's not 100% sensitive. So again, remembering to repeat that test if you think somebody is in the early stages. Please suspect cocci in anybody with CAP and a travel history to endemic areas who is not responding to standard antibiotic therapy. And I'm just going to put this up just so you guys can see. This is the treatment of coccidiomycosis, and we really decide to treat people based on what their immune suppression is and whether they have risk factors for progression. Fluconazole is the mainstay of treatment. In more severe cases, we use amphotericin B followed by fluconazole. And pregnant women should be treated with amphotericin and fluconazole in the second or third trimester. So in conclusion, there have been significant increases in temperature and rainfall, precipitation. These have already occurred. We are already in climate change now. This is going to only accelerate over the 21st century. Public health surveillance, I hope I have shown you the public health surveillance is absolutely critical in our understanding of these diseases, insects, animals, humans. We have to be able to identify trends and respond to them quickly in time. Lyme disease is the most important vector-borne disease that is linked to climate change in Canada. We're going to be hearing a whole lot more about Lyme disease in the future, even here in BC. Vibrio is our most important waterborne infection linked to climate change in Canada, particularly in BC. Emerging diseases like West Nile virus and coccidiomycosis may be on the horizon for us in BC over the next 50 years. And we have to stay alert to these trends, all of us, so that we can continue to expand our differential diagnosis, put things like Vibrio or West Nile virus, Lyme, things we don't see regularly. We are going to be seeing more of them in the future. So thank you. Questions, discussion?
So maybe, is there questions from the Zoom folks first? Maybe you could ask.
How do I see that?
Just maybe, just ask.
Okay, are there any questions from the Zoom folks?
Hi, Mary. If no one else wants to go first,
Oh,
I
hey,
will.
Ted.
Thank you for that awesome talk. Obviously, you only had 1 hour, so you had to pick and choose diseases that you were looking at. I'm just curious if in your research you came across anything worrisome regarding either hantavirus or rickettsial diseases, or other things that are fairly endemic in other parts of North America, but we don't see much here.
Yeah, so hantavirus, I didn't. I do know that hantavirus is risk here, but I did not see anything related to climate change in hantavirus. Rickettsial diseases, I did not specifically look at. It is worth knowing, this isn't rickettsia, it's anaplasma, but rickettsia is other tick-borne disease, that anaplasma, which is often a co-infection with Lyme disease, has also been reported more frequently in Canada. There was actually a big case of about 25 cases in Quebec of anaplasma in the last few years. So sorry, to answer your question, no, I didn't specifically look at rickettsia or hantavirus, but would not be surprised if especially the rickettsial diseases as vectors move up from the United States could become more common.
Thank you.
Any questions from the audience? Yes, Dr. Chan.
A lot of Canadians travel to Florida. So the malaria cases in Florida, is that due to climate change, and are we going to see more of that as things warm up there?
Yeah, so malaria or dengue even, which is probably even going to be more likely, have as much to do also with climate change and expansion of vectors as it does with failure of mosquito control efforts. So sometimes it can be, again, a perfect storm of waning, when we thought we had eliminated these diseases. And so vector control programs are non-existent, or have declined, and funding for those things have declined. And so I think, any of our patients who are traveling to Florida who come away with mosquito bites and a febrile illness afterwards, I mean, certainly something like Zika virus or dengue, I would be concerned about. Malaria, I guess a little bit less so, but could be a possibility for the future. But it's expansion of range, but it's also the failure of efforts to control the vectors.
So Mary, I have a question. So you didn't mention relapsing fever.
Mm-hmm.
Is that going to change in frequency in parallel to Lyme or not?
I have not seen any evidence that tick-borne relapsing fever and other Borrelia species, of course, has increased. In fact, some of my colleagues who are on the call might be able to comment on this better than I have, but I haven't seen one confirmed case of that. And I've been here for the last 12 years. So
I've seen several.
Have you? Okay, very great.
And it's a different tick.
Mm-hmm. Yes, of course.
It's a soft shell tick.
Yeah,
but
American dog.
So relapsing fever I've seen it predominantly from Idaho into central British Columbia.
Sure.
But I just wondered if there was data that showed any differences.
Yeah. Yeah, and I didn't know, not that I'm aware of, but again, there's no reason to think. I mean, this is why those things like e-tick are so helpful, because we should be submitting as many ticks as we possibly can so that we can get a sense of how many of them are dermasun or how many of them are ixodes, and is that changing over time? This is why that surveillance is critical. It may be here, but we're not looking for it. So,
and the second question is in Lyme disease in British Columbia, you mentioned people going to different parts of the world for treatment.
Yes.
How much of a clinical problem is it for primary infectious disease specialists in dealing with people who question the diagnosis or I mean, how do you view that issue?
The way I view that issue is that we do the best that we can to diagnose Lyme. Anybody who is seropositive, first of all, anyone who is seronegative, especially in late Lyme disease, it's very sensitive test. It'd be very unusual for somebody to have Lyme disease and be seronegative in a late stage. So that's the first thing. The second thing is that even if people are seropositive and have had an extensive course of antibiotics and still have symptoms, the way I approach it with people, and it is a very significant thing. This happens a lot, right? And the way I approach it with people is that your symptoms are real. It's very disabling for you. We don't know what that's coming from. It is very likely everything suggests that it is a chronic inflammatory condition. Your body's immune system has been revved up somehow after having Lyme disease or COVID. Yeah. Whatever you want to say, and that now that fire is burning in your body, and giving it more antibiotics has not been shown. We've tested it. We tried to see whether antibiotics are going to work. And in fact, they don't. We have 4 great trials that tell us they don't. In fact, they cause harm. And so I think it's really important to validate the patient, validate their symptoms, try to explain to them as best we know what the situation is. And then we just have to have better research and treatment of that chronic inflammatory condition.
Any other further questions? I guess I've been asking all the questions. If not, thank you very much for a wonderful presentation.
Okay, thanks.
They didn't give a salad.
No.
Yes, they're very slow today, very giving people wrong orders again. So you're gonna make the farm?
Yeah.
Huh?